So a good question, and in oncology medicine in general, life actually, rarely is anything 0 or 100%. So I think this sort of falls in that way. I think quite honestly, for switch maintenance, it's early second-line therapy. And I truly believe still that for those folks, if you follow the patients closely, particularly if you're looking at patients who have done very well with their induction therapy, either a PR, CR whenever I see one, and good stable disease, I'm very comfortable in giving them a few weeks off and following them, in 6 weeks with a scan or something of that nature before embarking upon delayed maintenance or second-line therapy. But particularly in those folks with stable disease, where I've changed is stable disease, particularly if they're a little bit symptomatic and I haven't seen a dramatic impact on frontline therapy. Someone that I would have waited, I'm actually really pushing to offer the switch maintenance therapy in that setting. Am I opposed to someone getting switch maintenance earlier? No, and we talk about that. Some patients like that safety net, and I think it's very reasonable. But so switch maintenance, like I said, I think that's sort of early second-line therapy. It proved yet again that second-line therapy works. The continuation maintenance is a different question, and I'll start with the ECOG 4599, the paclitaxel carbo-bev, followed by bevacizumab, a positive study over chemotherapy. And it fascinates me quite a bit that there still remains a lot of issues about the role of maintenance bevacizumab in that setting. I'm really not so sure why. It is totally true that it would be nice to have a study to see whether or not the maintenance played a role. And was it all related to the induction? You could also argue vice versa. But there isn't one. It's probably not going to be one. And it's you tested a regimen in toto. So that's the regimen. And the regimen includes maintenance. And you have to use it. Actually, as I said earlier in a debate with, Dr. Einhorn was doing the debate. It would be like someone saying, well, that data that you have for PEB or BEP for testis cancer is very interesting, and I understand the role of those 3 drugs and whatnot, but I've always thought that the 100 milligram per meter squared dose of etoposide times 5 was too high, and that you could get by with 75 per meter squared. Who would do that? Well, why does someone say, well, you know what, you don't really need the maintenance bev? And then there are people who don't use it. If you're going to use it, that's the regimen as is. So I think that one is, it's proven but not proven. It's proven as a regimen. It's not proven by component. And I do understand the concern for it, but short of a clinical trial, in my mind, that doesn't tell you to not use it. The other aspect is the continuation maintenance with pemetrexed, and that's one where there is some data there with, there's some pretty solid data that continuing that seems to provide a benefit. And so paramount, of course, was cisplatin-based therapy. The other question, though, is pemetrexed and bevacizumab the best maintenance? And that's where it gets confusing, because you've got the Point Break, which looked at the ECOG study versus PEM carbo-bev, followed by pemetrexed bevacizumab, no difference. Okay, so when you see a trial like that with no difference, and one is 4 drugs versus 3, and it's more expensive, different toxicity, or the 3-drug one. On the other hand, you have Avapril, which was pemetrexed cis bevacizumab, followed by pemetrexed bevacizumab, suggesting that the doublet was better, that the doublet arm did better. So there's some evidence that maybe the doublet's better. And then there's the new ECOG study looking at ECOG 4599 with Taxol, Carbo, and bevacizumab, and then changing up the maintenance as pemetrexed alone or the doublet, and maybe that'll help. So I think that's unfortunately a very long-winded answer, and one that isn't definitive because we can't be, because there's a little bit of data to guide us, but a little bit of data to confuse us. And the way I go about it is I look at patients and look at the histology. If they're non-squamous, I look to see if they're bevacizumab eligible. If they're bevacizumab eligible, I tend to use the paclitaxel, carboplatin, and bevacizumab arm, 4599, figuring if I don't use it, who will? And then use, the bevacizumab as is, and reserve the pemetrexed for second line. If they're not bevacizumab eligible, and there are a good percent of folks that are not, then I use a pemetrexed-based regimen, potentially with cis, potentially with carboplatin, and consider doing the maintenance pemetrexed in that setting.